Does fibromyalgia start in the gut? So if you follow Hippocrates from 2,000 years ago, we know that most disease processes start in the gut, right? Especially of a chronic nature. So how is this any different? The same underlying concepts that I talk about a lot in my previous lectures is that we have intestinal permeability, which we'll look at on a picture here in a second, and dysbiosis, meaning that our microbiome tends towards lower diversity and also higher levels of what we consider pathogenic organisms. Anti-lipopolysaccharide antibodies are usually produced by bugs. So you can actually see this. There's a test, Cyrex Array 2 is a great test to be able to look for the presence of LPS and also the presence of degraded gut barrier. So I run that test on a bunch of my patients. So if we have the entry of these endotoxins into the blood, this triggers systemic inflammation and also immune hyperactivation. And then we get the release of different forms of cytokines. Sometimes you don't see these things being elevated in fibromyalgia. So that is one nuance, again, because it's not always of inflammatory origin. So we have to kind of remember that. So just because you don't see inflammation doesn't mean that the patient doesn't have fibromyalgia, right? There's other things we need to be thinking about. But these inflammatory factors can also perpetuate some of the symptoms that patients feel, especially the malaise, right, and the pain. How do we feel when we have the flu, right? Oh, I'm so achy. I'm so tired. All I want to do is curl up in my bed and watch TV and eat ice cream. We're releasing all these chemicals into the body that tell your body to shut down. Right? Essentially, it's how these patients feel. They can't do anything because their body's in shutdown mode. Studies have also linked significant higher than normal levels of zonulin. Zonulin is a protein found in the gut barrier. And if there's high levels of zonulin found in the blood or even in the stool, that does give a good indication that there's intestinal permeability and we're getting the translocation of bugs across the barrier where they should not be. You could see elevated gut permeability was observed amongst fibro patients and chronic fatigue patients as compared to healthy controls when they were using a urine disaccharide excretion following an absorption test. Is a lactulose mannitol test. It's a pretty kind of older school way of looking for intestinal permeability. We're not going to really talk about that, but essentially what happened is that they demonstrated that they had leaky barrier, right? And there was elevated gut permeability in those patients who had fibro. So this is not surprising. It's probably not news to many people here, but it's still a very, very important concept because we're going to come back to this concept of mast cell activation. And why I show this picture here is, again, this is the barrier here. We have different proteins that make up our barrier, our tight junctions, as you can see that are labeled here. If the tight junction is damaged, we get the flow of parts of our microbiome or toxins or even food particles that leak across the barrier now into the bloodstream. That's what usually causes the activation of different neurochemicals in the blood, in the gut barrier, including we get the activation of mast cells. And the mast cells, which you can see, are directly related to pathways that trigger our nerves. So it's not uncommon to have patients who have mast cell activation, including the release of things like histamine and substance P, which is related to pain, that travels along our enteric nervous system and that also have direct interplay with our other nervous system, our peripheral nervous system and central nervous system. So there is this concept of interplay and mast cell activation and histamine found in patients who have both IBS. That's what this concept is looking at here, is IBS patients and patients who have other hypersensitivities, including fibro patients. And again, some of the underlying concept is histamine. So again, looking at the gut microbiome imbalances, this is, again, looking at the lactulose hydrogen breath test. The patient is administered lactulose, and then they measure the hydrogen in their breath over the course of a designated amount of time. And this is also oftentimes looking for the presence of SIBO, small bowel bacterial overgrowth. You could see that this particular study here, SIBO was observed in 100% of fibro patients. That's hard to believe. 84% of IBS patients, which of course is crossover between the two, and the pain intensity in fibro patients showed correlation with the higher amounts of exhaled hydrogen levels. So the worse the SIBO is, the higher the level of pain intensity. That poses the question, is this SIBO? That's what we need to be asking ourselves. Is this a derivative of SIBO? Yeah, probably. Is it a derivative of intestinal permeability? Yep, probably. These are the outside the box concepts we need to be thinking about. This study here looked at the gut microbiome of 77 fibro patients and matched controls. They had significant differences between the two groups of short chain fatty acids, of the bacteria that produce short chain fatty acids. And those are the three primary ones are butyrate, propionate, and lactate. And these levels have been linked to pain sensation. In fact, butyrate seems to reduce visceral pain in humans. So patients who have IBS, who have higher levels of butyrate, have less pain, have less visceral pain compared to those who have lower levels of butyrate. How do we get butyrate? Resistant starch, right? Resistant starch in the diet is one of the best ways to improve butyrate production by our microbiome. That's who produces the butyrate, right? So soluble fibers cause the microbiome in our colon to ferment the fibers. And then those fibers, they're able to create butyrate from that. And so this does relate to both IBS and to fibromyalgia. This is very interesting. Most bacterial species known to be increased in inflammatory rheumatic diseases, so systemic inflammation, have been found deficient in fibro. And it's in line with the overall notion, again, that fibro doesn't seem to be a peripheral inflammatory disease. Well, where is it coming from then? Maybe it is at the level of the central nervous system. Maybe that's what we need to be thinking about instead. And the last concept here related to the gut is antibiotics. Okay, this is a case control study. 44,674 cases of fibromyalgia found that both the total number of prescriptions and their timing was associated with fibromyalgia diagnosis. For example, those patients in the quartile with the highest numbers of prescriptions and with the longest exposure had the greater than 3-fold increase in fibromyalgia diagnosis, 3 times more likely to have fibro if the higher the numbers of prescriptions and the longer exposure. So do I ask all my patients about antibiotic history? You bet. Every patient on my new patient intake form answers that question. How many rounds of antibiotics have you been on? 0 to 10, 10 to 20, 30 to 40, or more than 40? And you'd be surprised at how many patients select the higher the numbers, 20, 30, 40, even 50. Sometimes patients are like, too many to count. So that's kind of why we ask these things. Some antibiotics, tetracyclines, metronidazole, seem to confer greater risk than others. But really the main focal point here is, again, the numbers of antibiotics and then the longer that people are on them. All right, so this is what I was mentioning a second ago, mitochondrial dysfunction. Fibro is clearly characterized by mitochondrial dysfunction. What do the mitochondria do? Well, first, we need to break everything down, right? The microbiome, our digestive organs break everything down, and we want to take those little teeny parts and move it into the mitochondria so we can produce ATP, right? That happens in the mitochondria. So this organelle is present in all human cells, but the more mitochondria exist in tissues with a higher energy demand. Think about your muscles and think about your brain, think about your heart, right? Those are the areas that use pound for pound more nutrients and more oxygen than any other organ in the body. So those are the ones that typically are affected most strongly by the etiology of fibromyalgia. Well, that's interesting. How do people feel with fibromyalgia? Their muscles are achy and sore. They have a higher level of sensitivity and their brain does not work. So these are such interesting fundamental concepts that if we all just go back and remember our anatomy, physiology, and biochemistry, we remember, oh, okay, this is what the mitochondria do, and it makes sense that these patients would have these types of problems. One study here demonstrated a change in the number and size of mitochondria in patients with symptomatic fibro, and the evidence has corroborated additional studies proving reduced mitochondrial concentrations and CoQ10 levels accompanied the increased expression of pro-inflammatory cytokines. So meaning, again, if the mitochondria are not working or if they're reduced in number and the CoQ10 levels are reduced in number, we tend to have a higher preponderance of inflammation inside the body. This all study kind of, again, is similar here, significant differences in certain bacteria levels in individuals with fibro compared to those without, as well as a marked polarization in reduced mitochondrial mass in both groups. So again, mitochondria are the energy powerhouses. How are we supposed to feel energetically well if we do not have mitochondria that are working. This is a great schematic. So again, what are the causes of some of these underlying issues? Again, SIBO, as we mentioned a second ago, endotoxemia, part and parcel of the same gut-related problems. The gut barrier is damaged. We're producing toxins that are found within the blood that are being released by the intestines across that barrier. Inflammation and mitochondrial inhibitors. So what does this do? It activates these things called microglia. Microglia, these are found in our nervous system, that then activate astrocytes, that then increase the production of glutaminergic, neurotransmitters, including glutamate. This causes central sensitization and fatigue and depression that is oftentimes seen in fibromyalgia. Not only that, but these underlying problems also cause mitochondrial dysfunction in the brain, and that exacerbates brain dysfunction, and this also goes right back to the microglial activation. So it is truly all a vicious cycle. In the body, this is in the brain, in the body, mitochondrial dysfunction promotes pain and the vicious cycle of oxidative stress, nutritional depletion, and additional mitochondrial dysfunction. So again, vicious cycle. So is there a connection between IBS and fibro? The classic GI symptoms of IBS are chronic or recurrent abdominal pain or discomfort and associated alterations in bowel habits. However, many people with IBS also suffer from non-GI related symptoms like skin rashes, muscle contraction, headache, myalgias have been reported in about 2/3 of IBS patients. Most importantly, fibro occurs in up to 60% of patients with IBS, and up to 70% of patients with a diagnosis of fibromyalgia have symptoms of IBS. And again, the takeaway here is both of these problems are functional health conditions. There is no real diagnostic gold standard for diagnosing either one of these problems. Yes, you can be looking at tender, painful points, but it doesn't really give you a lot of information, right? It's like looking inside the body and seeing nothing going on there. So this is a very interesting study here. So IBS patients have visceral hypersensitivity. Their inside of their body feels hypersensitive. In fibro, it's a condition of somatic, which is the skin and muscle hypersensitivity. So it's on the outside. So IBS on the inside, fibromyalgia on the outside, right? So fascinating. So this study here looked at female patients with IBS alone, both IBS and fibro diagnoses, and healthy individuals. Okay, they were measuring pressure, response to pressure, which is placed on the tender points. So like the fibro patients, patients with the IBS and fibro demonstrated somatic hyperalgesia. Again, that's increased somatic pain sensation when pressing on those points. However, patients with the IBS alone have somatic hypoalgesia. So people who didn't have fibro had less somatic pain sensation. Why? Probably because all their pain patterns are directed towards their gut and not their outside, right? So this study demonstrated that while IBS patients have increased sensitivity to visceral pain, they're less sensitive to somatic pain. But those who have both are more sensitive. So interesting to me. Hopefully you find it just as interesting as I do.